Well, thanks for having me tonight. I'm really excited to be here. I've done a little research on your organization, and it's fantastic what you guys are doing. And have that kind of support in the community is just incredible. I do want to take a few moments, and if we look at my slide set, really the first several slides, just an introduction to who Samaritan is, but I do want to talk about our advanced cardiac program. I'm very excited to let you guys know that we are the exclusive provider in South Jersey. We worked and we're a member of the National Partner for Healthcare and Hospice Innovation, which is actually a consortium of about 70 to 80 not-for-profit hospices across the country. NPHI, as they're called, work with the American Heart Association to develop I think a robust program. And really, you'll see the education booklet in the back that I'm really proud of, that I want you guys all to share with your families, really with anybody that's interested in doing that. But I thought what I would start with is really, let's talk about why a palliative care physician is talking to you guys tonight. When we hear things, we talk about hospice and palliative care, I want everybody on this call to understand that palliative care has become an integral part of the American healthcare delivery system. And really, palliative care, what we try to do is we try to really focus on the patient and their goals of care, as well as symptom management. And so when patients have really a serious illness, getting a palliative care provider engaged in that serious illness as early as possible really does help to improve outcomes. Because if you're waiting for a transplant, whether it be a heart, whether it be other organs, we know that there are certain challenges along the way. None of you ended up with your transplants feeling well. You were all feeling sick. And I'm sure you were having lots of side effects, lots of symptoms. And I think palliative care can make a real difference within that. I also think that after your transplants are completed, there are certain challenges, and we do want to talk about some of that as we get further along in our lecture, in our course tonight. Next slide, please. Just so you know who we are and about Samaritan, we are really devoted to the community. We are really trying to make sure that we promote dignity, healthcare, quality of life for those with serious illness. And I think that's really important. We actually have really a commitment to diversity, inclusion, and access to. We really believe that the community of New Jersey is an important issue, and we want to make sure that we do everything we do to provide programs so that to this community we provide, looking to make sure that we have the best interest in the community itself. We want to make sure that we have that inclusion, diversity, and access is really important to us, because it shouldn't be just for one category of patients. It should be for all patients, and they should all have access to palliative care and hospice care. Next slide, please. We are not-for-profit. We've been around for a really long time. We've cared for a lot of people. We have about 12,000 patients and their family each year. We have a very broad service. We serve Burlington, Camden, Gloucester, Mercer, and Atlantic counties. We take care of any patient that comes across our way. We believe that hospice is not just about medicine, but is really about taking care of the entire person, the entire body. And that means things like massage therapy, art therapy, pet therapy. I don't know if you guys, as you're going through your multiple hospitalizations, to have a dog or a pet come in by the room and give you a different way of looking at care. It's incredible when I see my patients. A massage therapist coming in and giving a back rub to a patient that really has been suffering, has really been having a lot of issues in terms of pain. It can make a huge difference. And we honor vets, which I think is really important. Next slide, please. And we do have a wide variety of services. Again, I point this out at this point in our talk because I want you to understand that hospice is no longer just end-of-life care. Hospice is really looking upstream to get us upstream as far as possible. We want to get involved in terms of palliative care when patients are diagnosed with a serious illness. And I bring that forward because it's important that as soon as we're involved and engaged in a case, patients' outcome really do improve. And we do know that I did a little bit of research on heart disease and heart transplants today. We do know that about 2,000 to 3,000 heart transplants are being done each year. There's about 3,000 people that are on the list that are waiting for heart transplants. And it's said that 1 in 10 people in this world will only 1/10 of the people in this world will get a transplant. So really, we're not transplanting as much as we should. And those patients that do not get transplants still are left with lots of symptoms that need to be managed. Next slide, please. Just remember the Medicare hospice benefit, which is when you are not able to have aggressive care, includes a full range of support for the family and for the patient. Next slide, please. And what's important with Samaritan, the reason that we've decided to go and really try to improve advanced cardiac support is we have inpatient hospice centers, which can be used very aggressively at treating patients with acute symptoms. So for example, the patient that has heart failure that needs an IV dose of Lasix, we can give in our centers. We have centers in Voorhees, we have centers in Mount Holly. We use those centers for acute care intervention in our hospice patients to make sure that they get the best care possible. Next slide, please. What I really want to talk to you guys tonight about is really palliative care, and then we'll get into the advanced cardiac program. Palliative care is an important part of care for anybody that has advanced illness. It can be given at any part of your care, whether it's at diagnosis, whether it's through your treatment course, whether it's during your aggressive care, whether it's during more conservative care. It can be given before an intervention, it can be during an intervention or after an intervention. I think with what you guys have been through, you understand that there have been challenges. Obviously, you guys have been strong patients that have fought very much to get the care that you need, and hopefully you're all feeling better. I heard that Jim is now in his 27th year, which is actually amazing to me that he's done so well after that, and we wish him 27 more good years with that. But there are challenges, exactly. There are challenges throughout those 27 years, and I'm sure they didn't all go smoothly. And we want to focus on what is important to patients' quality of life. What makes quality important? How do you define your quality? What is life meant to you? So is it about spending time with your grandchildren or your children? Is it about having meals with your family? One of my favorite stories is a gentleman I took care of, and he was a gentleman who actually ended up having cancer, and he was a fisherman. He said, "Doc, if I can't fish, I don't want to live this way anymore." So we all inside ourselves have a definition of quality of life that makes sense. And the reason I mention that is I want you guys to think about advanced care planning, which we'll talk about at the very end. We also make sure that as you're going through your treatments, you don't need to suffer. You don't need to be short of breath. You don't need to be in pain. My cardiac colleagues who are very, very good sometimes forget that. Sometimes they see people as a medical disease process, not necessarily a whole person. So what will happen is they will interpret a shortness of breath as being you need more Lasix, where maybe you need a little bit of touch of morphine to help you breathe better, or maybe a little bit of anxiety medication to make you relax a little better. Again, these small interventions can really go a long way at improving the quality of patients' lives. My staff is big. We actually now I think we have 12 nurse practitioners and 4 physicians. We do a lot of visits, mostly inpatient. We're spreading out into the outpatient service. We're very excited that to get involved in heart failure and advanced cardiac disease because we know that there's a big need for that. Only a small percentage of patients that have advanced cardiac disease actually get seen by a palliative care specialist and get the benefits that they get from a palliative care specialist. Next slide, please. We also at Samaritan have decided that we need to be able to meet patients where they are. I'm sure there were times when you guys were seeing your physicians and you could feel like you could not get out of your house. It was just too much effort to get to the doctor's office, too much effort to get to the hospital. We have invested in a home visiting physician practice that will allow us to do visits in patients' homes. And this practice typically sees patients for a long period of time, but is very happy to do short interventions, see them for 2 or 3 months while the patient is recuperating or while that patient is having a more difficult time. They're available. They really have a focus on patients that are geriatric, but they take care of all patients across the board. And they really do provide really good at-home based primary care. Next slide, please. All right. Now, this is the heart of the matter. This is really what I wanted to get to. The advanced cardiac care program. The manual that you'll see on the left side is really a very good guide in terms of how we manage heart disease. We know that, as I said, less than 5% of cardiac patients really get the hospice benefit, even less get palliative care. We know there's a great discrepancy between underserved communities. This handbook can be used by anybody because we know that with any kind of serious disease, cardiac disease can actually get involved with everything. We want to make sure people are living well and living healthy. So it talks about how we manage our medications. It talks about making sure we have a good list of our medications, how we use them, knowing your meds, knowing your side effects, knowing how they interact. In your guys' case, with transplant, I'm sure your medicine lists are longer than my arm in most cases. There's a lot of meds that you've been taking, a lot of interactions. How do we manage those? How are you managing those? And how can we help support that management? Really doing good medicine reconciliation, making sure that the medicines that you think you're taking, making sure that you have availability. When we look at a lot of these medicines, they're extremely expensive. What happens if you can't afford to take these medications? What happens is as you progress, it's harder to get the medicines because you can't get to the drugstore or you can't afford to get them. You can't manage them. How do we help support that? And that's good, really, medicine reconciliation. What about exercise? What about diet? Those are things that we need to start paying attention to make sure that every single patient has a good, healthy diet. Running the Broad Street run is something that again is amazing, is wonderful. But are our patients doing that? And are we encouraging them to exercise? How do you start an exercise program after a surgery? How do you start an exercise program if you are short of breath or if you're full of edema? What happens with those patients? How do we get that patient encouraged to do that? What kind of food? What kind of diet? What should we be eating or not eating? And those are questions that we want to help walk the patients through. I think the other really important thing is really how do we manage the mental and spiritual stress that's put on patients, especially transplant patients. We were talking about this a little bit earlier. You guys are checked up a lot. You got lots of checkups. I'm sure when those checkups do come, there becomes a little bit of anxiety about, are they going to find something this time through? What is that checkup going to mean to me? How are these results? If a result doesn't come back right away, does that mean things are not going so well? And that anxiety, even post-traumatic stress, if you will, really does make a huge difference in how patients function in their lives and have a functional level. So we want to make sure that we're addressing all of those issues to, again, really approach a patient as a whole patient, not just a transplant patient, not just a heart patient, not just a kidney patient, but really as a human being. And how can we make their quality of life as best we possibly can make it with the support of a full team? Our advanced cardiac program at this moment in time really is on the hospice side. We're working to get into the palliative care side. Basically, what you get is an advanced practice nurse who really has been trained in advanced cardiac disease. They will do a good evaluation and help collaborate and work with the patient's primary cardiologist and family physician. I think that's a very important issue is communication. Are the specialists talking? Is the specialist talking to your family doctor? What does that look like for you? And how does that affect your care? Because if the family physician or the cardiologist doesn't know what's happening when you decided that, things can happen that may not be in your best interest. So how does that collaboration happen? How does that coordination of care begin to happen? And I think coordination of care in medicine is something that is oftentimes lacking. And you guys have been through the system, so you probably understand, that coordination. I think transplant does it the best in our system, but still that coordination can be very difficult. A team approach to taking care of patients. Not only do you get, a practitioner, but how about some social support? How about a social worker? How about a chaplain helping to support some of those emotional and spiritual needs that are really lacking in the rest of the medical system? I'm going to encourage you to go onto the Samaritan website and really download this caregiver handbook. It's full of incredible resources. And I think it really is well done. Again, the American Heart Association worked in collaboration with MPHI, and they did a fantastic job in putting this together. And it really keeps all the information in one place. And again, it can be used not just for heart failure, but for all patients, because all disease processes need to have a holistic approach to their care. The other thing I know that you guys have done through your treatments is you have been fighters, because you don't get through transplant and not be a fighter. You don't get through the symptoms of transplant and not be a fighter. But we do know that at times diseases progress despite our best efforts. And I think it becomes important as you have managed through this that you begin to start thinking about advanced care planning. I think advanced care planning is something that, again, our advanced cardiac program does tend to focus on. What is important to you? What kind of things make a difference to you? What happens if you can no longer speak for yourself? Who makes those decisions? Who's involved in that decision-making process? We do wish that every patient can make decisions till the very end. That's not necessarily the case. And we want to make sure that your voice is codified. Next slide, please. I'm sorry. And so just so you know, with the advanced cardiac program, we are being taken care of nationally. We're working on WebMD. Next slide, please. Back to advanced care planning. It's important that we actually codify our wishes in terms of what is important to us if we can no longer help our families make decisions. This is very important. Even patients that have been through traumatic treatments, have been through and have gotten through treatments. What I hear often as as I get through these treatments is, if my family only knew what I wanted, if they only knew what my wishes were, I would have gotten the right care, not too much or too little care. And oftentimes I have families come back to me after their loved one has passed away and said, "Doc, did we do the right thing?" And my question to the family always is, well, what did your loved one tell you? And the answer oftentimes is, we never had the conversation. We never talked about it. So I don't know. So that is a very important issue for every patient, whether you're a transplant patient, whether you're a cancer patient, whether you're a well-healthy, 70 or 80-year-old. You need to understand what is important to you. The 5 wishes, which is also available on our website, goes through some very serious questions and very interesting questions. Who makes decisions if I can't make them? Is it my wife? Is it my daughter? Is it my son? Who's strong enough to make those decisions? Who's going to honor my wishes? What's important to that person that can help make those decisions? What treatments do I want? And so we all have ideas of what treatments we want. We want to be treated aggressively until something happens to us. So for example, when I did my advanced directive, I like to talk. I love my family. I like to talk to my family. I know there's dementia in my family. If I can't talk to them in a rational way, then I don't want to be kept alive, not knowing who my family is. I don't want aggressive treatments. I don't want antibiotics. So I was very clear to my family, this is my line in the sand. This is when I have said I've had enough. And so all of us have that within us that we need to kind of codify for that. What about our comfort? Do I want to be awake, talking to my family, even though I might be suffering, or do I want to be more sedated? What kind of comfort levels do I want? How do I want to be treated by the team? How do I want to be treated by people? Do I want to be in my house? Do I want to be in a nursing home? Do I want to be in a hospice facility? Do I want to be in the hospital? And all these questions are important. I've had patients that have said yes to all of those things. I've had patients say, Doc, I don't want to be at home. I've had patients said, whatever you do, keep me at home. So how do you want to be treated? What brings you comfort? Is it music? Is it touch? Is it food? What kind of things make you feel better that are not just medications? And then what your loved ones know about you? Well, to me, this is an ongoing thing. We should be talking to our children, our grandchildren, our spouses about our lives in general. We should be sharing our trials and tribulations with our families so they understand what our lives mean, but really writing things down. This is when you do some historical review, some reminiscing. I tell families all the time, get the story, because in today's world of medicine, we lose the story. We don't understand who patients are. We don't understand what you've gone through. We don't understand what your greatest triumphs are, what your greatest troubles have been. What is important to you? What makes you who you are? So getting that written down can really help your loved ones make decisions if you can no longer make those decisions. And that really does reduce the burden of caregiving on your family, because they don't have to make a decision because you've made it for them, and they just have to honor your wishes. Patients that have gone through aggressive treatments like you guys have with transplant, we tend to want to be more aggressive because that's the way we do things with people that have gone through aggressive care. And that works out fine, but we want to identify what is important to you at that moment, what makes sense to you. So in summary, I think that we did talk about the advanced heart program. Again, to me, it's a holistic approach, looking at patients, not just as a medical disease process, but as a person that have both emotional and spiritual needs, providing a team to support them, not just through treatments, medications, but through exercise and diet and social support and psychological support, which I think is really important. And then finally, advanced care planning, making sure that your wishes are noted and making sure that you have a good definition of what a quality of life means to you. And that's really all I had tonight. I just wanted to quickly touch on some things. I hope that was helpful. I would be happy to answer any questions that anybody might have. And where I think I do best is answering questions. So if anybody has questions, I'd love to take some time to do that.
Yeah, Steve, thank you very much. That was great. Yeah, I've got a couple of questions. You talked a lot about, or a fair amount about the coordination of care, and you're right that for the most part, us transplant folks have got it good in some respects, arguably in many respects, and so we do have teams that follow us. Many of us also have primary care doctors and that and those kinds of folks, and maybe even one or two others. How do you how do you guys fit into that coordination? How do you interact with our primary care or our kidney transplant team or whatever it might be?
Yeah, again, I think with palliative care, we're collaborative. So I want you guys to feel, and what you'll hear with palliative care is you have to go on to palliative care. As a palliative care specialist, I'm just like one of your specialists. I'm just like one of your kidney guys or your heart guys. I want to follow along and give my expertise to symptom management or to goals of care discussions. We typically will send letters off to our referring physicians. I do pick up the phone a lot and call people. I find that, in today's world of medicine, we've forgotten how phones work, and I think that, a direct phone call, especially if I see a patient that's not doing well, my next step is always a call to their primary care physician or their primary specialist, if you will, because I think sometimes, and this is, again, my distant background is in family medicine. So I'm used to wanting to manage patients across the entire spectrum of their lives. But when you have specialty treatment like transplant, like cancer, sometimes the primary care doctor is kind of peripheralized a little bit because so much time is spent with those specialists, and the primary care doctor kind of gets put off to the side. I do think that we need to pick up the phone and call. And I will tell you, in today's world, my cell phone is one of my most valuable tools because I have a lot of physicians' phone numbers in there that I shouldn't be sharing with anybody, but I am happy to pick up the phone and call somebody. So if I'm really concerned, that to me is the best way. Is that direct communication is really the best way to make sure that your care is being the best care possible.
Okay. There is a question that came in from the chat from Barry, and he asks, can palliative care doctors order meds?
Palliative care doctors can order meds. It's an interesting world right now, and the meds that we typically get involved with are symptomatic medications. So things like anxiety medications, a little bit of narcotic for pain and for, believe it or not, shortness of breath. And what's happened in some of the laws in the state of New Jersey, as well as Pennsylvania, palliative care physicians have been kind of excluded from all the onerous regulatory things that have to be done with narcotics, for example. So we have a little bit easier. We tend to want to make sure that we're not overprescribing. We are very concerned about the risk of side effects and addiction and those type of things. But absolutely, we can prescribe meds.
Okay. Okay, Jim Gleason, please talk about those same questions when you progress to hospice care level.
Yeah, so I think the hard part with hospice care level is knowing when it's appropriate, because if our goal has been aggressive care and moving forward, I think sometimes we have to decide when our quality of life is below which we wish to continue to push forward, and only the patient and their family can decide that quality of life and that goal of care. I give you my example of what my kind of quality was, but we all within ourselves have that. We have to really look. And when I see patients in my office for a palliative care consult, I challenge them to tell me what makes your life worth living. What are the things that you wish to do? And then we can go back and we can determine whether the treatment is actually honoring those wishes. So for example, if somebody's being hospitalized every other week because they're in heart failure and they're spending week after week in the hospital and they can't be at the table with their family to eat, then it might be time to start talking about a direction of comfort and a comfort-based approach, which would be hospice care. Typically with hospice, what you get from that is you do get an aggressive team of a nurse, a social worker, a chaplain. A lot of things with the hospice comes down to the medications. And there's always a discussion, especially with transplant patients, about the cardiac meds because of the expense of the cardiac meds. hospice is responsible for all meds related to the terminal disease, if you will. And so by the time people get onto hospice, typically the rejection medications may not be, often are no longer indicated because they're just not working. So a lot of patients that we see are because the rejection meds have stopped working is what it comes down to. So the question is, do you take meds that may not be working or not? And that's again, a goal of care discussion that you have to have with that. I would hope that any patient, this is any patient, but any transplant patient that's going to go onto or think about hospice has a good conversation with a palliative care provider, because that way they can help clarify all those goals of care, all the patient's wishes and desires, and clarify some of those issues.
I just want to add, if I can, Stephen, my in-laws, both my father-in-law 10 years ago and most recently my mother-in-law, have been a beneficiary of your hospice care in their end of life. And I cannot say enough. It was Samaritan that came in. Your staff were amazing. I don't know who benefited more. Certainly the patient did, but the caregiver, my wife, just can't say enough about the care and understanding and empathy that your staff had in dealing with a challenging patient who wanted to be home. Clearly it was at her end of life. She was 94 years old. And the respect that she was treated with from your people are just beyond complimenting. They're just amazing. So please pass that back as a thank you from this family. I know my wife sent it back with the people that came, but I would highly recommend, when you get to that point where there is no hope and you accept the fact that, hey, this is a natural part of life, end of life, the care, the medications, the access to everything that we needed is just a real blessing in life. So thank you for all that you're doing. Samaritan is a great service, and I can't say enough about your organization.
Well, thanks for those kind words. I will tell you, the medicine of end of life care is pretty easy. It's all the other things you talked about. It's the staff, it's the nurse, it's the psychological and psychosocial support, it's the emotional support. All those things, to me, is the magic of hospice. That's what hospice is really about. And as well as bereavement for 13 months after the patient passes away, which I think is a really important issue. That loss is difficult, and we want to make sure that we're working with grief and loss after the patient passes away. So thank you so much.
Thanks, Jim, for those comments too. Actually, a couple of questions from Barry, insurance related. Well, I'll read them both. Is outpatient palliative care covered by insurance? And arguably, maybe we're talking Medicare and we're talking commercial insurance, if you will. And similar question: what are the insurance criteria for inpatient palliative care?
Okay. So palliative care in general is covered by insurance, and and especially Medicare. The key with palliative care is I don't bill for palliative care. I bill for symptom management. I bill for typically things like shortness of breath, pain. I will bill for heart failure. So I bill regular, what they call ICD-10 codes for those that are familiar with that. I'm sure you've seen it on your EOBs. So I bill for regular diagnoses, and we do get reimbursed. We do get reimbursed for both outpatient and inpatient. We do about almost 12,500 visits in the hospitals in the area, both at Virtua as well as Jefferson, New Jersey. I will tell you that, to me, the criteria for an inpatient palliative care consult is that you have a life-threatening or a serious medical illness. And it could be, it doesn't have to be life-threatening, just a serious medical illness. It could be, I tell people all the time, the first heart attack is a serious medical illness. Because what happens after that is the doctors do a great job. My colleagues do a fantastic job from a medical perspective. They manage the cholesterol, they manage, the aspirin, they manage maybe blood thinners, they might cath you, might get stents. But it's that emotional component that really is never well managed, because we know that after a serious shock to your system, we know emotionally you're never quite the same. And it needs to be managed in a different way. So if you're 55 with a family support and you have a major heart attack, who's going to help you get through that emotionally? If you have a cancer diagnosis, who helps you emotionally get through that? And that's where palliative care, I think, really can make a huge difference. I would tell you that in the hospitals, it can be tough to get an inpatient palliative care consult. I have patients that I see on the outside that get admitted to the hospital that I'll call the attending physician and say, hey, I'm seeing this patient, Here's their medications that I'm giving them. Here's their problem list. Can my team come by and see them? And the answer is no. And I kind of say, what? Hold on, So it can be a little difficult to get an inpatient palliative care consult, but I would be persistent. I would be your own advocate. And I think that it can make a huge difference in terms of outcomes of both your symptoms as well as your goals of care.
Actually, you raised an interesting phrase, advocate. So my question revolves around advocacy, and it revolves around the family and caregivers.
Yep.
And their role in advocacy, if you will.
Yeah, so I think it's important. I think, and we found this with COVID, by the way, because over the last 18 to 20 months, what's happened is families have not been allowed in the hospital for the most part. We've had some moments where visitation has loosened up a little bit and now it's tightened up again. But we've had patients in the hospital who've probably have had worse outcomes than they would have because the family's not there to advocate for them. If you are sick, if you are on medications, if you're in an ICU on a vent, you can't advocate for yourself. And the family can't be at your bedside saying, what medicine are you giving my loved one? Have you turned them recently? You're not there. So advocacy, I think, is so important. Where I find myself in palliative care is we try to be the patient advocate as much as possible. And to me, it's about the goal of care for the patient. What's important to the patient? One of my favorite stories I tell all the time is when I first started this years and years ago, I got asked to see like an 85-year-old gentleman at the hospital, and he had a stroke. And this gentleman, the team felt he wasn't strong enough to have a feeding tube put in, which surprised me because typically hospitals put feeding tubes in anybody. They called me to get involved because he was adamant. He wanted his feeding tube. I walk in and I talk to him and I ask him, well, what's so important about the feeding tube? He looks at me dead in the eye and says, Dr. Goldfine, I have a girlfriend in the nursing home that I feed every day. If I'm not there, nobody will feed her. So I advocated for him to get the feeding tube because that way his goal of care was the most important thing. So that's kind of the advocacy that we kind of get involved with. I think with palliative care, it's not about taking services away. It's not about a subtractive plan of care. It's really about the goal of care, what's important to you as a patient. So if that goal is to remain aggressive, then I'm right behind you. I'm going to be as aggressive as you want me to be. If the goal of care is to be less aggressive, then I'll be there too. So it really is, it comes down to that goal. So that advocacy is trying to define what's important to the patient. And then let's fight for that goal of care because that's what's really important.
Okay, well, that's great. Thank you very, very much. Yeah. Anyone else have any questions of Dr. Goldfine?
Yes, this is Susan. I have a question. Yeah. One thing I'm trying to figure out: are you associated only with certain hospitals, or are you totally independent? Or
yeah. So Samaritan is an independent, not-for-profit that's been in the air for at this point in time 42 years. We are on the medical staffs at Virtua and all 5 Virtua hospitals, including Lourdes and Camden, Burlington, Voorhees, Marlton, and Mount Holly. And then we're also in the Jefferson, New Jersey hospitals, and that includes Stratford, as well as Washington Township and Cherry Hill. And so that's really our main focus of business right now. And we're part of the medical staff. But we are an independent, not-for-profit organization. We like to say that we really are hopefully owned by the community. The community drives our decision making.
No, but for instance, if somebody were in Abington, Jefferson, in the Philadelphia suburbs.
So I know that Jefferson Center City has a very good palliative care team, as does University of Pennsylvania. I don't know if they go to Abington, but you can ask. So I would always say, ask if you have a desire or need for that.
I know Abington has their own palliative care because my transplant coordinator, nurse practitioner, left transplant, went into palliative care, and he works. That's one of the hospitals he goes to.
Okay. All right. Great.
Well, my question is personal. It's a looming issue, and I've been told that Abington is sort of like, oh, you're how old? Oh, you're going to die anyhow.
Yeah. So I think
the way you're speaking.
And again, I can only speak from my hospitals and what my team does. I would hope that the patient's voice is the voice that we listen to. And I live that every day, and I really want you guys to walk away saying that, palliative is about really my goals of care. I think you have to balance goals of care with reality, though, a little bit, because I've had some patients, and this is mostly in the cancer world, by the way. Somebody has a stage 4 pancreatic cancer and says, I want to live for 2 years to see my daughter get married. Not so much, And so I think you have to really try to see what's a realistic plan of goal of care, and gently, kind of have that conversation. When I meet with families that say, have a goal of care that may be too aggressive or too much, you gently try to walk them through what makes sense and what doesn't make sense. So really, we can have what we want to happen to us, but the body doesn't always participate within that conversation. So we have to use the goal of care, both what you want emotionally, but also what your body can tolerate and what it can't tolerate. So you have to figure out that line between the two of them.
Okay. All right, thank you.
You're welcome.
Anyone else have any questions for Dr. Goldfine before we let him?
I don't really have any questions, but I just I'm reliving something because a friend of mine just died under a week ago, and we had many of these discussions about palliative versus hospice. She had no family. So basically, my husband and I and a friend who's a doctor out in Portland, a neurologist, were making the decision. And we knew that she didn't want any kind of excessive treatment. And her liver was failing, and her kidneys were failing, and her heart was failing. And she also struggled with depression. It was a very easy decision at a certain point. Like we had many discussions over the time because, of course, we were making the decision without her input. But it was clear that, palliative was okay until there was really no hope of her getting better. I mean, when my husband and I saw her sometime in the middle of last week, it was clear to us that it was time. And sometimes you have that, but sometimes you have, if it's a family, and I've dealt with that too, you have family members who want to keep the person alive because they can't imagine the person dying. And so they don't want to put them on hospice, although, people can be on hospice for a long time.
And that's correct. And that's why I go back to my advanced care planning and my advanced directive. I think that, those decisions are very difficult, or can be very difficult. And if the patient's voice is not there, then it becomes even harder. If the patient was able to tell you exactly what I want, and be clear on their wishes, then it makes it a little bit easier to make those decisions. And there's a lot more clarity. Unfortunately, in today's world, only about 25 to 30% of patients actually have advanced directives. Most of those are not actionable because they're not clear enough. And so what happens when they can't make it, when we're not able to make decisions any longer, it leaves the family, or in your situation, friends of the family trying to figure it out the best they can. And then what happens, that patient gets delayed going into hospice. So they go into hospice only for a day or 2 or 3. And I will tell you that we can manage symptoms in a couple of days, but the real hard work of hospice care is acceptance, bereavement, grief, and loss. And that can't be managed in 2 or 3 days. That takes 2 or 3 months to manage. And, I think there's a lot of patients that miss the opportunity to get really good hospice support because of the lack of clarity of advanced care planning and goals of care.
Wow. Well, thank you really very, very much on behalf of TRIO Philadelphia and National and all the folks that are watching this tonight and watching it in the future as well. I think you've given us some really great information, a lot of great ideas. I think you've educated us in many ways, and obviously one part is the advanced cardiac program with the Heart Association, but you've touched on many other areas of things that are of concern, arguably for all of us watching you tonight, and we greatly appreciate it. And if anyone has anything else to say, please do. Otherwise, we'll let Dr. Goldfine go.
Doctor, I think that was an excellent, easy to understand, and if we're around to be cognizant at that stage in life, I'd love to have the blessing of you and the Samaritan service to make it easy for that finally passing. Thank you.
And thank you guys. And I'm honored to speak with you guys, and stay well and stay healthy.